Good afternoon. Thank you. It's truly an honor and a pleasure to be with you here. Each time that I've had the opportunity to come to South America, and each time I've come to the Pan American, I know for certain that I've learned an awful lot more than I've taught. For those of you who had the pleasure of being in the very last session, the one that just preceded this session in this room, those esteemed speakers, Dr. Lucas, Dr. Moore, Dr. Peitzman, Dr. Rizzoli, Dr. Scalea, those have been my professors and my role models, and it is on the one hand a great honor to follow them. It's on the other hand very intimidating as well. I want to thank, of course, Dr. Puyana and thank Dr. Jimenez as well for their kind invitation to be here. And I was asked to give this historical context for damage control, which I've delivered on a whole number of occasions. And though the term damage control has been closely associated with my name, that's probably all it's been, is associated with my name, because the development of the concept of damage control surgery, that idea, that notion, emerged out of great collaboration from many of the speakers that we heard just before me and many others across the United States and indeed across this continent as well. It emerged out of a tremendous need that caused a radical change in the care of trauma patients. And you'll see, and I'm happy to say that that change is still ongoing today. It was, in its own sense, a form of revolution, an uprising against a very traditional technique which was yielding less than optimal results. So a total or radical change in a circumstance or a way of living or thinking, a far-reaching change in the ways that we thought about things and the ways that we behaved. And I'm giving a very United States-centric view of this because it's what I have. It's how I grew up. And it came out of the 1980s when these figures were so important in pop culture in America at the time. Those two very famous basketball players, Kareem Abdul-Jabbar and Magic Johnson. The Boss, or Bruce Springsteen, who's still very active. It was the time of big hair with Bon Jovi and, of course, Ronnie Reagan and Nancy Reagan as well in the 1980s. And in the 1980s, we were really very much on the heels of still of the Vietnam conflict, when, in essence, there had been a rise in trauma systems development across the United States on the basis of the lessons that had been learned in Vietnam. One of our great trauma forefathers, Donald Trunke, produced this landmark paper in Scientific American in 1981, which described this trimodal distribution of death, where there was a peak of patients who died immediately, then those that died several hours after resuscitation. Again, for those of you who were here at the previous session, you heard about who some of those patients are, and those that die much later from multi-organ system failure. At the same time in the United States, as trauma system development, trauma centers began to develop. There were hospitals that took on the role of caring for injured patients in a very focused way, where a rapid and organized and well-coordinated response would be taken to meet the needs of a patient who was bleeding. And within those centers, there were teams of people who were focused on this as well, focused on trying to make a difference for patients who were in desperate situations, going through that carefully choreographed dance in an effort to stop bleeding, getting a patient to the operating room and stop the bleeding. A theme from the cases that were discussed so brilliantly this morning, North versus South, a theme that we just heard through the last several hours of discussions. And then this happened in the United States as well, that these very same surgeons who had been pushing the system development and pushing center development, and those who had brought teams to the bedside to react to a patient's need in a very carefully coordinated way, began to provide educational opportunities for others like me to learn about injury care. And we were zealots, very much focused on trying to manage these patients who at that very same time in our country were so often suffering as a result of gun violence. And there was a change in weaponry as well. It wasn't the usual, what we would call Saturday night special, a low caliber single shot revolver, but a more rapid firing weapon which had a higher caliber and a higher muzzle velocity, leading to much greater tissue destruction. At that time, when I was reading Dr. Lucas's papers and Dr. Ivaturi's papers and Dr. Feliciano's papers at the time, there wasn't a lot in the late 1980s, early 90s written about this new problem, this new wounding mechanism, those patients who had much greater tissue destruction and who were falling off the physiologic curve quite rapidly. You can see it reflected here on this graphic, which demonstrates the number of firearm deaths that were occurring on an annual basis between 1970 and the year 2000. And what we're focusing on, in essence, is this time frame right here, where this peak was occurring, and these were the patients that we were seeing in our country, which was a change for us, with a different wounding mechanism and a different sort of physiology that was showing up at the door. In fact, we knew that on average at our trauma center at the University of Pennsylvania at that time, the majority of our patients didn't have one gunshot or two gunshots, but almost between 3 and 4 gunshots each. So it led to a much more complex injury pattern that was complicated by rapidly deteriorating physiology. So you could see that the stage was set for a change to occur in how we would manage these patients. The systems had been put in place to get the patients rapidly to those trauma centers. The centers had been developed. There was a singular focus of the surgeons who were in them. And now we had the proper clinical substrate. We had an increase in gun violence in urban America, and the stage was set for a change. The only missing element in that revolution is the frustration, and we were soon to begin to experience the frustration that you feel when you apply what is standard therapy at the time and still end up with a bad result. You know that you've done all the things that you need to do, all the things you've been taught to do, and you've executed them properly, and you still end up with a very high mortality rate or a dead patient on your hands and blood on the floor. This is a paper from Dr. Feliciano from 1988 where he talks about the management of abdominal gunshot wounds, 300 consecutive wounds. Again, these were the sorts of resources that I went to at the time to try to learn under the guidance of Bill Schwab when I was at the University of Pennsylvania, an 88% survival rate. But if you looked at those patients that had major vascular injuries, that represented over 80% of the deaths. And in patients with major vascular injuries, their overall survival wasn't 88%, it was 60%. And if you looked at those patients that had a major vascular injury or 2 major vascular injuries with multiple visceral injuries, their survivorship was 10 to 15% using standard techniques. So a change had to occur by virtue of our fatigue and our frustration. And this wasn't just happening at the University of Pennsylvania. It was happening at centers across the United States. At that time, Dr. Scalia was at downstate at the Kings County Hospital in New York, and at that time, Dr. Lucas was at Wayne State, where he is still today, and Dr. Feliciano was with Dr. Maddox down in Houston, and I can go on and on at my colleagues and senior mentors across the United States. They were all struggling with this very same problem and considering alternative approaches. I may differ in my opinion just slightly from Dr. Rizzoli. It really wasn't in 2003 that we recognized that from the point of energy transfer that there was changes in coagulopathy. You could find that in the European literature that I know of as early as the 1980s. And certainly the Germans showed us that in the early 1990s, that there were fibrin degradation products that you could find in patients, in the blood of patients that were injured on the Autobahn in Germany. And we certainly knew that our resuscitation techniques and our surgical techniques would oftentimes lead to this triangle of death, if you will, or the bloody vicious cycle, which was exacerbated by both the resuscitation style we were using and maybe the operating room techniques as well. And I'll try to bring that into better focus as we go along. So what was out there? What could be done differently? Well, again, no one owns an idea. You can go back even as early as 1983 and probably even earlier into the 1970s. Again, I want to reference Dr. Lucas and some of his work, where an alternative approach using a rapid termination of ileotomy, or a rapid bring the operation to a rapid close after initial control of contamination and control of hemorrhage and contamination had been out there for a long time. Look at that paper by Talbert in 1992, where they're describing a mortality rate of about 36 patients, a morbidity rate of about 43% in patients like this who had major vascular injuries and multiple visceral injuries. Dr. Talbert worked with Dr. Scalia in Kings County in New York. So this began to emerge as a possibility. Maybe we should do something other than operate on these patients in a traditional way, where they got exploratory laparotomy, 4-quadrant packing, definitive control of hemorrhage with reconstruction, definitive control of contamination with complete reconstruction, and closure of the abdomen. So during the time that I was a young faculty member at the University of Pennsylvania, working with Bill Schwab, and having started so many of the relationships that I still have today with senior mentors across the country, we came up with this 3-part approach. Someone had to somehow bring this into focus, because we were all experimenting with an abbreviated laparotomy approach. And this 3-part approach of initial control, contamination, abbreviation with packing and temporary closure, then going to the intensive care unit to restore physiology, what John Morris at Vanderbilt at the time would call the secondary resuscitation, making these patients warm, restoring their acid-base balance, restoring their blood volume, and then bringing them to definitive reconstruction later on. And we talked about that casually on Morning Report, and used to refer to it as damage control, which is a term from the Navy that refers to the capacity of a ship to absorb damage and to maintain mission integrity. And it just seemed to make sense. For a period of time, we called these patients the walking dead, because they would come in enraged, oftentimes in shock, but still fighting for their lives. And within 30 minutes, they'd be in the operating room with most of their blood volume on the floor. But this term, damage control, seemed to stick. Hey, what did you do? Yeah, I had a damage control patient last night. Yep, we did damage control. It seemed somehow to resonate and make sense. And when we pooled this, our data, and I want to try to put this into some sort of context now, so many years after the fact, because it's almost 20 years ago, it really resonated from the podium at the AAST at the meeting in Louisville, Kentucky. Many of the names I've already mentioned, including others like Ken Maddox and Leon Pachter, lined up at the podium, lined up at the microphones on the floor after I had the opportunity to present this paper, which was my first paper at the AAST. Talk about a blind pig finding the apple. It seemed to make sense. The elders came forward and said, this is something that we are doing, this is something that works. I want to tell you something. This was a 46-patient paper. There were 23 patients who were historical control and 23 patients who were in the study group. And we showed about a 10 to 15% survival rate in one group and almost a 90% survival in the other group. That's all it was, 23 patients, after a lot of work. And more of culling the data. A little more of the backstory, because you heard Andy Peitzman speak a little bit earlier. The first draft of that information was presented at the Pennsylvania Committee on Trauma paper competition by one of our fellows named Chip Phillips at the time. I was already in practice a couple of years. Tomorrow I have the privilege of being a judge at the resident paper competition for the Committee on Trauma here. At that meeting, when that was presented, Mike Rhodes, Andy Peitzman, Bill Schwab, a gentleman named Dan Diamond, they came up and gave us suggestions as to what to do with that data to try to make it more sensible. It was very much a collaboration of colleagues working on a problem to try to save patients' lives. Not dissimilar to the debate that you heard just prior to this about what the proper ratio of blood and blood products should be in an exsanguinating patient. It seemed to make sense, to the best that we could tell in doing a cumulative review over the years that followed. It looked like there was a clear reduction in mortality as a result of using this approach in patients who had severe shock. But you can see that the morbidity was extremely high. The complications rates were high. But this was really based on trading off complications for survival. If we could get the patients to live, we'd learn how to manage the complications. That fact in and of itself, I think in some ways led to a rejuvenation of trauma surgery. Rejuvenation, a phenomenon of vitality or freshness being restored, because so much came as a result of having these patients who were so desperately sick in the ICU, but they were still alive. One of them, of course, was to work out, and so much work was done by Dr. Moore and others to work out the physiology and the pathology, if you will, of coagulopathy and trauma, something that's still evolving today, a theme that you heard over the last several hours. And a whole host of techniques in surgery that were used to abbreviate. This is an animal model just showing a vascular shunt, a temporary vascular shunt. The first one of these that I did was in 1991 in a patient who had a shotgun blast to the right ilioinguinal region. There were others who were doing it at the same time, but this was something, again, what I call one of our dirty little secrets that we were doing because it wasn't standard teaching, but it seemed to make sense at the time. The use of temporary intravascular shunts, the avoidance of enterostomy tubes, which were considered standard therapy, the avoidance of stomas. To do a primary anastomosis on a patient who had severe contamination 3 days post-injury in the face of edema and in the face of a large amount of transfusion was pretty much surgical heresy. But we did it because we knew if we brought out a stoma, with all of the changes in geometry of the anterior abdominal wall, it would have problems in and of itself. And it seemed to make sense to take a risk on the anastomosis and percutaneously drain the leak than it was to take that patient and give them a stoma. Even just the concept of delayed definitive GI reconstruction of any kind. And of course, the use of the judicious use of a planned ventral hernia. So much of what we were dealing with at the time we didn't realize was based on this. It wasn't really a failure of operation. It was a failure of resuscitation. Exactly the topic that was discussed over the last several hours. We were still practicing resuscitation techniques at the time as they were taught to us by Dr. Shires as a result of the work that he did in his research lab in the 1960s, not quite 40 years prior, still using this approach as dogma with large volume crystalloid resuscitation on the basis of our understanding at the time of the redistribution of extracellular fluid as it goes into both intravascular and intracellular spaces, into the extracellular space from the intravascular and intracellular spaces. That dogma stood for a very, very long time, and we were very much influenced by this. I borrowed this image as an adaptation from Vicente Gracias, who is here as well and is speaking at this conference. We would push these patients into a non-flow dependent state of cardiac output so that their oxygen delivery was as high as it could be. And as soon as we got to that level, we'd given enough fluid, we would then add inotropes, throwing more logs on the fire, if you will, to maximize oxygen delivery and consumption. But at the same time, living under the concept that more is better, again, something you heard Dr. Lucas talk about earlier, that maybe more is not better, we pushed these patients into a tremendous amount of edema. And in fact, it was so difficult to ventilate them. Whole societies sprouted as a result of the PEEP Society in the United States. The Positive End Expiratory Pressure Society came up as a salvage mode of mechanical ventilation, largely in part because we were doing these very, very aggressive resuscitations. And sadly enough, or maybe fortunately enough, we became experts at managing intra-abdominal hypertension. During my residency, my chairman always used to say, Frank Rosato, he'd say, beware the surgeon who's expert at managing complications, because he probably has had a lot of complications. And we did. We were creating complications on the basis of these survivors. And so we began to understand this concept of abdominal compartment syndrome, where you have elevated intra-abdominal pressure and associated systemic signs and symptoms leading to a problem within a compartment that caused a pressure-flow relationship problem. That is, venous return was severely impaired, end organ function was severely impaired as well. And Dr. Ivaturi took us through this, our understanding of this cycle of ischemia and reperfusion that occurs when we were using these large crystalloid resuscitations, repleting into vascular volume, developing more pressure in the abdomen, and then we would begin to see perfusion would go off, go down, then we would resuscitate them back up again, and their cardiac output would go down again. And in this cycle of ischemia reperfusion, we were creating a perfect model for multiple organ dysfunction syndrome. What we knew to do at the time was to leave the abdomens open, and that's what we started to do in essence, hence the science of the open abdomen, as we're going to be discussing in large part over the next hour or so. If you go back and look at the literature, you can see that virtually every system physiologically in the human body is affected if you have abdominal compartment syndrome. These are all observations from a variety of basic science and clinical studies that show us that. And we also know that a series of a scheme, if you will, for managing intra-abdominal pressures by grade. This was developed by Birch, grade 1, 2, 3, and 4 with bladder pressures of 10, 15, 25, and greater than 35, giving us guidance as to how we should resuscitate and manage these patients. So for the grade 1s, a normal volemic resuscitation; for a grade 2, a hypervolemic resuscitation; grade 3, open the abdomen in the ICU; grade 4, go to the operating room. This is a form of a beatitude. It's something that we recite to ourselves at night, so we have something, we know basically what to do, but of course you individualize for each of these patients. All of this emerged as a result of now having these new patients, these damage control patients who are alive. And novel dressings, homemade dressings for management of the open abdomen. This is the VAC pack that was described by Barker. Though I can say a lot of people were using it across the country, similar to damage control before the paper ever came out, where we're using this sort of homemade VAC device, and then KCI and other companies came onto this VAC dressing sort of approach, which has now led to things like the Abthera device and other devices. We were oftentimes left with these sorts of patients. And in 1990, 1991 or 2, these patients were sort of few and far between, and everybody would say, oh, don't operate on that. Don't do anything with that. But honestly, the patients were coming and seeing us in the office. They were looking right across the exam table at us. They needed something done, and so we began to try to sort through how to do anterior abdominal wall reconstruction, and that's been, again, now another near 20-year odyssey of sorting through how to take a patient on the left and get them to look like the patient on the right, using component separation techniques and stripping the skin graft off the intestine. Perhaps one of the biggest surprises, at least for me, and this was really a very important thing, is what happened in Operation Enduring Freedom, Operation Iraqi Freedom, when our United States military, you heard the name Holcomb mentioned so many times over the morning, and others, Don Jenkins, you see John Pryor there, who died in December of 2008. When the United States military began to embrace damage control, the surgery, and take damage control across the echelons of care. This is a summary of that concept by Lauren Blackburn in Critical Care Medicine in 2008, where in essence damage control is really utilized as a surgical technique across all of these role facilities, from the battalion aid station all the way back to the continental United States. It's damage control surgery on the move, done across really continents, in order to now to achieve the lowest battlefield mortality in the history of warfare. So it's made a significant difference. There's no question about it. But now it's really time for us to really rethink it again. Let's take a look and see and recapitulate this theme again. What's really happening now? Because I would contend that the frustration is still rising. It's rising again now around the high complication rates that occur in these patients. Everything in the abdomen that can happen will happen, and that overall complication rate is still about 35%. And an open abdomen can be very, very frustrating to manage, particularly if it's accompanied by the 15 to 20% fistula rate that we know can occur. On the low end, it's 5%. On the high end, it could be 35%. And so maybe what we heard in the previous session on specific resuscitation techniques, and what I'm going to try to foreshadow for what's coming is really maybe with what happened in the war, we're at the end of damage control surgery, and we're at the beginning very much of damage control resuscitation, because the focus as a result of Operation Enduring Freedom and Iraqi Freedom has been on a change in resuscitation, and you heard that in great detail. This is Peter Ree's paper from Arizona. Peter Ree was in the military and left the military after 20-some years, went to Arizona, and when he got back to the University of Arizona and took what he had learned from the war and put it in place at his civilian trauma center, he saw his rates of damage control surgery start to go down as the resuscitation techniques changed in a way that was significant for the patients. So an important concept here. How did we get here? Well, Dr. Ivaturi talked about resuscitation endpoints and the challenges we have in those resuscitation endpoints, in that they're for the most part not accurate, and for the most part they're very high-level resuscitation endpoints. A whole series of myths in our understanding of crystalloid, confusion about transfusion, and then of course what I call our inflammatory fugue state, as we're constantly trying to figure out which pro-inflammatory markers are important and which ones are not important. Let's not forget the basic physiology of shock. This paper on the leaky buckets paper that was written by Asher Hirschberg, Dave Hoyt, and Ken Maddox talks about the importance of understanding pressure-driven bleeding and intrinsic hemostasis. If anything has come into clear focus out of the current war, it's been this, that fluid resuscitation in and of itself can exacerbate bleeding. This is a swine model that's been bled down to a mean arterial pressure of about 30 and given no resuscitation. And you can see in this model that lo and behold, their pressure starts to recover because they have intrinsic mechanisms that they can use to control bleeding. They vasoconstrict, they clot. This is not a new concept. This is 1992, Kowalenko's paper, a swine model showing that that in a swine hemorrhagic shock model, that the best survival were in swine that had their mean arterial pressures at 40, not 80, at 40. In fact, 80 looked more like a mean arterial pressure of 0. And then this paper by Dr. Maddox in 1994, which we've all seen and heard, and many of us said, that just can't be true, where he talked about immediate versus delayed resuscitation for hypotensive patients, permissive hypotension, and the focus on being certain that we don't raise hydrostatic pressure, we don't have increased pressure-driven bleeding by increasing the pressure too much and popping the clot and exacerbating the bleeding. You saw this, at least 3 speakers showed this particular graphic. As we've all been trying to bring this into greater focus, the war has helped us do that. It's helped us think very critically about what the ratio should really be. And you can see that debate is raging now, which is important because it's going to give us the answers that we need. So we have 2 things that we've talked about. One is permissive hypotension. That's one, where you're really limiting volume, maybe giving no volume. And we talked about what we've seen the United States military teach us and what the investigators from the earlier session discussed, a 1-to-1-to-1 ratio, or maybe a 1-to-2 ratio, or a 1-to-3 ratio. That's a low resuscitation. And then this last concept, slow resuscitation. Again, Vincente Gracias just came in the back of the room. This is adapted from his graphic, where we're now doing a euvolemic resuscitation. We're no longer driving these patients up into that non-flow dependent state and then adding inotropes, we're slowly adding crystalloid back. Slowly adding it back. And we're adding it, and we're still trying to sort through, again, if you listen to Dr. Lucas very carefully, exactly how much crystalloid we should add it back, and more importantly, when we should add it back. This I would call the third phase, would be slow volume. And one thing I think we should challenge ourselves to do, for those who spoke earlier, and for those I want to challenge you as well, what we haven't quite sorted out is what exactly the phases of this resuscitation should be. Dr. Lucas discussed that his phase 1 would be no volume, permissive hypotension, low volume, 1 to 1 to 1 or 1 to 2, whatever it is, in the operating room. Slow volume is the resuscitation that occurs after. That would be his phase 2. We need some clear nomenclature, and this is again my attempt to teach the people at my institution about how we're going to apply this. No volume, low volume, slow volume. We can quibble about exactly how we should carry out each of those phases, but we at least have to define those phases, and I think they're not clearly defined yet, and they're not defined by patient population either, penetrating versus blunt. All of this has come as a result of the next revolution, if you will, as the frustration has grown that damage control surgery alone is not good enough. I hope this sets up Juan Duchesne, who's going to be speaking in just a few minutes. This is his paper that came out from the American Surgeon in February of 2011, where he's talking about combining damage control surgery and damage control resuscitation, and demonstrating, and I won't take a lot of time to do this, that in the non-damage control resuscitation group, when the emergency department ratio of FFP to packed cells was 1 to 5 versus 1 to 2, you can see that. Take a look at the crystalloid, about 5 liters versus 1 liter, and look at the 30-day survivals, about 80% versus 60%. We need to sort through to the next level how exactly we're going to use damage control resuscitation in conjunction with damage control surgery, and maybe we'll see what would be a dream of mine as damage control surgery begin to decrease in its necessity and decrease in its utilization. So my thesis has been that really damage control was a revolutionary break from a tradition and the mainstream surgery, and it led to a rejuvenation in critical care, and we learned a lot. But now it's time for us to recapitulate and rethink how we could do better. And so much of what I've heard over the course of the morning gives me great hope, because I know we'll continue to try to do better and better. Hopefully that historical context has set the stage for today. Thank you very much.